Yeah, I'll request other participants to kindly mute themselves. Today we are going to see a very interesting case and quite a rare case, I would say. So let's first go through the case presentation and then we'll start off.
Good evening, everyone. Is my screen visible?
Yes, sir.
Yes,
I can see that.
Yes, sir. Today we are going to present an interesting case which we saw at our clinic. So let's start with it. Firstly, coming to the patient particulars, patient name is Gauzia. She's a 37-year-old female patient. She's a PhD doctor. She works as a scientist. So he came with chief complaints of lower abdominal pain since 22 years, but it hasn't been aggravated since 2 to 3 months, and lower back pain since 3 to 4 weeks. Moving on to the history of presenting illness. Patient was apparently all right 22 years back. Lower abdominal pain, it started, which was insidious in onset, continuous, which has been aggravated since few months, 2 to 3 months. Initially, it was relieved with medications, but now even with medications, it has been not relieved. According to the numerical rating scale, yes, it comes to 8, where it's a severe pain. So again, lower back pain since 3 to 4 weeks, which was insidious in onset, continuous. It aggravates on sitting, and it is also not relieved with regular medications. According to NRS scale, it comes to 10, severe intolerable pain. Coming to the past history, she is a known case of pelvic endometriosis with rectal spread. So there is no history of any radiation of pain, no altered bowel and bladder habits. Moving on to the past history, she has underwent diagnostic laparoscopy with adhesiolysis with bilateral ovarian drilling, chemoperturbation in January 2022, and patient had underwent laparoscopic rectal and uterosacral endometriotic nodule excision in August 2023. And recently, before coming to our clinic, she had undergone ganglion implant block, and patient had almost 50% of pain relief, but it was quite for a short period of time. The pain, it started again after 12 days. And post-surgery, she had a bit of pain relief for a few months. So she currently she is on progesterone hormonal therapy. Coming to the history of drug allergy, she was allergic to amoxicillin and paracetamol. According to the psychological assessment questionnaire, a score of 8, which comes under the mild depression category. On examination, abdomen, pelvic area, it was tender bilateral, both perineum and pelvic areas. And at the coccyx, there was mild tenderness. This is her old allergy screening test, so which shows a bit of allergy to amoxicillin and paracetamol. So provisional diagnosis, it's an endometriosis with deep infiltrating endometriosis with rectal spread. With a differential diagnosis, we kept it as recurrence or incomplete resection and pudendal neuralgia.
Okay. So I think all of us have gone through the case. So I'd like to call in Dr. Samresh here. And with a patient presenting with lower abdomen and low back pain. So usually as a pain management specialist, what all things do you need to keep in mind? What all diagnosis should come to our mind, sir?
I think sometimes the endometriosis pain sometimes is very frustrating for the patient, for the physician to treat it. So all other differential diagnosis for that sometimes can be present. And this patient was saying like, there is some psychological issue. So you have to keep in mind those are very difficult to treat. So I think keep in mind with other differential diagnosis for the action is.
Okay. Okay. So basically, as you rightly mentioned, endometriosis itself is very difficult to treat, and it's a rare thing for a pain management specialist, because the patients usually they get managed by the obs and gynae people itself. Whenever it is being referred to a pain specialist, then I think we need to be even more careful about how to handle with this. So,
That's correct.
to all the young physicians, the thing over here is that things are not very straightforward. You can have a lower abdominal pain. The patient can present with a back pain. So you have to keep in mind the spectrum of diagnosis which can result, right? Okay. Now, I'd like to call in Dr. Sunil over here. Dr. Sunil, what are the examination points which are very important to look at?
Sorry, sir.
Examination points.
Yes, sir. Examination, she had tenderness, sir, all over the lower abdominal perineum region. So even she had tenderness over the tailbone coccyx also. A bit of sitting for prolonged time was painful for her. Otherwise, no, nothing like any radiation of pain, nothing like that. So no numbness or weakness or the lower limbs, nothing.
Okay. So, Dr. Samaresh, a presentation like this, what investigations do you think we need to focus on?
But I think from pain physician point of view, you should have a thorough investigation. History taking is more important. Nowadays we always think for what first thing when we see the patient, we in our mind we think of what kind of treatment we are like intervention you are doing. But thorough examination is much more important. You might have some other coexisting back problems that's possible. So I think the basic investigation will start probably. That you're saying that like there is pain in the coccyx area, so probably examination followed by X-ray of the lower back, including the coccygeal area, is more important. I feel that will be. And so one more thing I want to just, I don't know whether it's relevant to you
Dr.
when I was
Samaresh,
practicing.
hello.
Yes,
Dr.
yes,
Samaresh,
sir.
I think
Yeah.
there is something in the background. Your voice is not very clear.
Is it? Uh, just a minute, sir. Just a minute. I'll just change my location. So I was just saying, sir, I think
Better,
we
better.
never used to bother when, hello? Is it clear, sir?
Yeah, better, sir. Better.
Yeah. So I was not, like, when I was practicing in India, I never used to bother for patient name and details. I don't know whether this is still there the same thing, because nowadays a lot of people they are the considering the data protection, this and that. So I think the first thing I was saying, like slide, you should not tell the proper name of the patient and proper things. So they might, nowadays everything is so so the sensitive. So be careful when you are presenting something. Don't give the patient ID and yeah. So the examination point is more important, followed by investigation you are asking. Probably I'll go for a simple X-ray of the lower back and the coccyx area. There is a possibility. You are saying she's a scientist. I don't know how, like, I know it's endometriosis is proven by the laparoscopy, but still sometimes there is a back pain also can cause, those things. She's a scientist, so just ask in the history whether she has a lot of sitting job and sort of things. So that might be important. Hello?
Yes, yes, yes. Correct.
Yeah. Anything you want to add, sir? Anything you want to add?
Hello, Dr. Samresh.
Yes, sir. I can hear, sir.
Yeah, your voice is still a bit muffled actually.
Network is showing full, sir. Hello?
Yeah, yeah. Still a bit muffled actually, but okay. All right. So, investigations part, basically, we just spoke a bit about the imaging, X-ray, and the other imaging modalities. If you see over here in the history, there was a bit of diagnostic lab, diagnostic hysteroscopy done. So, I so I'll be asking Dr. Sunil to put more light on it in the past history.
Yes, sir. She was almost suffering from the pain almost from 22 years. Actually, she was earlier put on all the type of medications for the pain, and finally, that actually two procedures she had undergone. It was one in 2022. It was like diagnostic laparoscopy with adisolasis and bilateral ovarian drilling, ovarian drilling for the ovarian cyst, and she had this endometriotic nodules in her rectal and uterosacral ligament. So that was also removed laparoscopically. These procedures are usually once that medical management is not helping her in pain management, then we'll go for the surgical approaches. These were the two procedures which she had undergone for the same, sir. But she was not relieved for a longer period of time. Only for a few months, pain was a bit reduced. So many articles tells that even with after the surgical procedures also, the pain may persist.
Okay, so before we go into the management part, I'd like Dr. Sunil to go ahead with a bit of a presentation on the management.
Yes, sir. Management of this patient, it's usually multidisciplinary management. Uh, One thing is to involve the gynecologist and pelvic physiotherapy by focusing on strengthening of pelvic floor muscles. Clinical psychology, because almost this chronic pain will have a bit of depression in the patient. So cognitive behavioral therapy would definitely help the patient. And even if at all the pain is persisting, then we had a plan for some interventions like ganglion impaired neurolysis or superior hypogastric plexus block. Uh, with this, we had prescribed her with some medications for the pain, which includes an opioid fentanyl transdermal patch, 25 microgram, which is to be changed every 3 days, and tapentadol 50 mg BD and duloxetine 20 mg in the increasing doses.
Okay. So all these medications were prescribed. So can you comment on what happened after the medications were prescribed?
Yeah, yes, sir. Yes, sir. So once on the day we prescribed the medicines, and the next day, the follow-up day, she had an allergic reaction to the fentanyl patch. Fentanyl patch or lignocaine as such. She developed rashes all over the body, and there was no any breathing difficulty, bronchospasm, like only rashes all over the body. So she was admitted to the hospital and she was treated for the same. At the same time, the allergy workup was done at the same hospital. So allergy screening test was done, anti-TPO antibody was done, which was negative. Total IG was in normal limits. Only one positive finding was autologous serum skin test was positive. So their immunologist They have diagnosed her as a chronic spontaneous urticaria of autoimmune type.
Next slide.
So they had advised for the following. So trial of buprogesic patch at the hospital. So even for that buprogesic patch also, she had developed rashes. Then they had planned for autologous serum injections over 4 weeks, 3 to 4 injections. So again, she came to us with severe pain of 10 on 10 with aggravated tailbone tenderness.
Next slide. Anything is there, or are you done?
That's it, sir. Then the next management, what we planned the next this time.
Okay. So basically, yeah, that slide you can remove. We will talk about it later.
Yes, sir. Yes, sir.
Okay. So now we have a patient over here, severe pain. Of course, the diagnosis is right in front of us, rectal endometriosis. And we started with a management, right? Kind of a step ladder approach, wherein painkillers, analgesics, co-analgesics, and even opioids have been started. But again, the patient has developed a severe allergic reaction. So, Dr. Samaresh, what do you think we can do when a patient has, literally allergy to each and everything in the especially? So, like fentanyl patch was put allergy, buprenorphine patch was put again allergy. So, how do we go about patients wherein there is allergic reactions to medication?
Sir, I don't know. According to the criteria, I don't know, the fentanyl patch starting initially was the right thing or not. I'm not very sure because we don't give fentanyl patch to the patient here, at least. We just go gradually going upwards rather than follow down until you are just having the analysis. I don't know, fentanyl patch initially, I don't know. They say we give fentanyl patch only for like a patient. We can't do anything at all. There are a lot of things I think we should try because see, I think that there is definitely there's pelvic endometriosis with rectal thread is there, but I think there is some component of toxicodine also that you tried before the gangrene, but it helped. So I don't know that should we go for any radio frequency treatment for this one, or sometimes for pelvic endometriosis, superior hypoplastic block also is very good one. And definitely, we give fentanyl as patient is not comfortable. We should just say, like, explain to the patient, like, we can't just take this one. She's definitely a special one to with those kind of things. We can try different things like nowadays. I think PRP is a good one. Good option. Dry needling PRP or sort of counseling to the patient with a multidisciplinary team, discuss with other people what we can do best for her, putting her in the loop. This is, I think.
Okay. So basically, now if you want to
I don't know
look
whether she was
other
allergic to lidocaine as well. What you told lidocaine that I heard something. Lidocaine, anything?
Lignocaine.
lignocaine.
Yes, sir. Yes, sir.
Lignocaine also there was allergic to lignocaine.
Yes, sir. When they had given ganglion impar block, she told little bit of allergic reaction was there for that also. That was not confirmed actually. Even lignocaine, there was a query allergic reactions.
Yes, sometimes some patients if they feel something different, for example, little warm sensation or anything, they will say, "Oh, it's not allergic, it's allergic." It may be
Dr.
possible.
Samaresh,
So,
hello.
yeah, yes,
This
sir.
patient actually has a proven allergy.
Who
Even
like to complete the
yeah, even when the ganglion implant was done, actually, I don't know if been mentioned in the history, Dr. Sunil, that she developed allergic reaction to that also. What was
Okay,
injected,
okay,
big block.
okay.
That also
That is the
developed an allergy, and she was admitted for almost 2 days in the hospital. Post
that's yeah, okay.
yeah,
So probably
and
dry needling and PRP injection should be best for her. I think it should think because we can't give medicines, we can't give any So she's allergic to fentanyl. So I don't know that lower opioids may be beneficial. Sort
See,
of.
as compared to others, then I think it will become quite difficult, right?
Hmm.
Because
Yeah.
not only that, she also had allergy to paracetamol also.
Oh my God.
So it become quite a complicated case. Allergy to paracetamol, NSAIDs, opioids, injectables also. Now, as a pain physician, what do we do? Hands are tied. So
I know,
right
I know. It's very
now,
difficult scenario.
here I'd like to bring in the importance of multimodal management, multidisciplinary management. So, Dr. Samarish, could you outline the importance of physical rehab psychology over here?
See, most of the patient having chronic pain, they have some psychological component. Like the multimodal approach is I think is very easy for the patient, for is safe for us because it basically here if you like if you practice in this part, they will say share the responsibility. So that means you are not taking any sole responsibility, you are dividing the responsibility to others. And when sometimes it's happening, the patient is coming to you, for example, every month or every 15 days, she will think like psychologically, she might think, oh, I'm going to him and it's not affecting. Okay, so but when she's coming, if you like different people, like for example, her own gynecologist, clinical psychologist, or any sports physician or like physiotherapist, pharmacist, if everyone decide and explain her, maybe she'll take it seriously. Yes, I have something. And long-standing pain, there is definitely a psychological component, and I think this is very we sometimes we just neglect this part. So it's very important to just to keep in mind in this part. And we never know which patient is coming for what reason. Because whenever I'm seeing any young patient coming to the pain clinic, I am really little bit of extra cautious because sometimes they don't like their job, they don't like their life, they don't like their bosses. So a lot of the psychological component is basically having multifaceted involvement. So they might, and what's their expectation? Is what their realistically they want, what the treatment they want. Some patient will, I find a lot of time, they're asking for some kind of benefit. For example, young patient working in the army, they don't want to go to their job, so they need, most of them they will say the back pain. So again, proper history taking is more important. And if you think like, no, this patient is very difficult to manage, complex patient, complex scenario, so better to involve the multidisciplinary treatment and do a multidisciplinary meeting. That is more important. And practically, how possible it is in our place in India, I'm not very sure, because the cost is one of the thing. Cost is one of the thing, and the how acceptance on the patient side is little difficult. So yes, there is definitely chronic pain. There is a definitely multidisciplinary meeting, and the approach of the multidisciplinary approach to treat the patient is very, very important.
Agreed. Agreed. I think for such chronic pains, definitely multidisciplinary approach is what I think is very important. All right. So we'll just take in a few questions from the comment section. We have a few questions over here. One question is, will alcohol neurolysis of superior hypogastric plexus help in this case? So what do you think, Dr. Samresh? Will it help? Hello, Dr. Samresh?
Sorry, I was in mute. I'm not sure about the alcohol. Definitely might be helpful. I've never used it. That we are getting permission to use phenol. So I don't know phenol. Have you used phenol anymore at any time, sir? I'm not very sure.
Few times, yes, used phenol. Advantage with phenol is that you don't have to give a local anesthetic only, because that
That's true. That's true.
inherent local anesthetic action. Only problem is the duration of pain relief is shortest with phenol. It's as per literature, it's around 3 months, 3 to 4 months. Alcohol is
Hmm.
around 6 months, 6 to 7 months, and RF is almost a year. So that's So
Yeah, yeah,
sympathetic acid plexus block, see, any sympathetic plexus block, first is you need to uh, take care by confirming it. That is by doing a diagnostic test. In this
yeah,
case, ganglion impaired gave 50% pain relief for the patient. But again, patient went into the complication and all. Yes, one approach is if you think of neurolysis, then yes, RFA is one thing, which is the definitive treatment over here because the diagnostic block gave some relief. And the endometriosis is in the rectal area. So RFA of the ganglion impaired is one particular thing which can be thought of. But again, the inherent problem lies over here with the endometriosis, right? So when the gynecologist was asked, could you mute yourself? Somebody is, yeah. So when the gynecologist was asked about how to go about with this, they were told that now final option is to resect a certain segment of the rectum. The patient being around 34 years, 34, 35 years is not ready for this. She wants to pass at least 5 years, 5, 6 years, wherein, she can do. So again, I'd like to call in Dr. Samaresh. So, sir, do you think Dr. Samaresh is there with us? Yeah.
yeah, yes, sir, yes,
Okay.
yes.
Dr. Samaresh, do you think there is a role of spinal cord stimulation in this patient?
That's right. That exactly I was about to tell you.
Yes.
There is some room for the spinal cord stimulator for those kind of patient when everything, so we can't do this one, we can't prescribe the medicine. There is a certain rule of the spinal cord stimulator. And nowadays, I think there are not in. I know the Barts Foundation Trust
Yeah.
in London. Even I'm not doing any spinal cord stimulator. Even I'm not trained with this, but I have attended a few meetings and. So they don't place the test lead. They're saying they do a lot of counseling, this and that, and if they're doing it directly. That was the latest. I think I was there on last week one of the meeting. They are saying no, we are putting if the patient is like following those criteria, we are putting without any test lead. They are doing it directly. Okay. So yes, definitely there is some rule. If she follows all the criteria, there is definitely the rule of spinal cord stimulator. Yes.
Yes, correct. Thank you for outlining the management. Now I'd like to call in Dr. Sunil. Dr. Sunil, there is a question in the chat box over here. They was kindly brief about autologous serum injection. Can you shed more light on this? Autologous serum injection. What is autologous serum?
I feel it's more like sensitizing the body with autologous serum at the multiple period intervals so that the hypersensitivity would be decreased.
See, basically, autologous serum therapy, it's an adjunct therapy. Okay, it's used alongside treatments like antihistamines and all that because the serum as such is thought to contain factors that can help desensitize the patient to the various allergic reactions. So here what they do, it involves injection of the patient's own serum to potentially reduce the allergic reactions. Okay, again the blood is centrifuged, the serum is separated and then it is injected back. Okay, so that's how it is done because this patient, if you see, almost literally she is allergic to each and everything. Okay, so that is what is the problem. So I think we have explained about even the most of the management part. So Dr. Sunil, can you just put up your management slide now and go through the management options?
That I think you should make me the host again.
Yes, yes. You are the host now. Can you try sharing your screen?
Yes.
Your screen is visible.
Yes, sir. So the management what we planned for the patient was like USG guided dry needling and pelvic physiotherapy. Uh, and according to the immunologist, we just told her to stop all the medications. So we thought of giving a trial with IV opioid trial because many a times there may be allergic reaction to the patches, but not when we have used it IV. So better IV test dose can be given at the hospital setting under monitoring and tried it and gynecologist review also.
So, one thing is that, I've seen in quite a number of patients that transdermal patches, for example, fentanyl, right? Patients tend to have reactions, but the same patients do not have any reaction to IV fentanyl. So this is a kind of a thing which can be tricky for many of us when you're prescribing the medication, because patients mount a response to a transdermal opioid, but the same opioid given IV, they don't have a response. Okay. Again, when you try looking into it, it says that whenever a transdermal patch is put, there is some ingredient which is there for it to stick, right? The glue kind of a thing. So some patients are allergic to that as well. Right said and done, that you need to be careful about this particular condition. Other thing over here is, in this patient, and one more thing which can be thought of, a low cost option as well for patients who cannot afford spinal cord stimulation, is ultrasound guided dry needling. It has been seen that ultrasound guided dry needling, especially around for chronic uh, neuropathic pain around the pelvic region, around the rectal region, with the help of usage of dry needles, it has responded, and the patient have had some kind of a relief. And of course, pelvic physiotherapy is also very important. So now I'd like to call in the participants. Do you have any doubts? You can unmute yourself and you can ask. We have the
So can
expert.
you give low dose ketamine infusion? Is
Definitely
it like
can be tried, but I think first we need to do a test dose and then see whether she's wanting a response or not. And definitely that is one thing also which we can think of, Dr. Samresh. So do the participants have any doubts? You can unmute yourself and you can directly ask. We have our expert faculty with us. Okay, so no doubts. Then I think we have almost rounded this case again.
Yes, sir.
Quite
Sir,
an
we just
yeah.
update today what's patient. We have collected some details regarding the patient.
Yes,
So
yes. Go
we
ahead.
just get the same, sir. So update what we got today from the patient, that she had received IV opioid with no hypersensitivity at the hospital. So uh, she was relieved with pain by the use of IV opioids, and repeat USG abdomen and pelvis transvaginal and transabdominal scan was done. And she has been prescribed with injection leuprolide, which is a GnRH agonist for the pain, and she has been advised for surgical resection. That's what this is the recent scan. It was done on 30th of June. So here you can see there is some hyperechoic anterior wall thickening of rectal tissue where she has endometriotic nodule. So they have again uh, told to undergo surgery for the removal of the nodule, since that is the main cause for the pain.
Definitely, I think surgical dissection is the curative option over here, actually, for this patient. And as you were mentioning, that she had allergies to transdermal patches, but the IV opiate she didn't have a problem, and it has served to help her relieve the pain. So that is another very important point which we have taken from here. So again, thanks for the update, Dr. Sunil.
Yes, sir.
This is real-time update. I think this was shared today, right? With us from
Yes,
the,
sir.
and this is what is a real-time update from the patient per se. But I would say that, yeah, this is quite an uncommon condition to present with, and for us as pain management specialists, we should be prepared to have a wide array of differential diagnosis in our minds, because the various cases which can present, it can lead to a lot of confusion if we don't take the right steps. So thank you very much, Dr. Sunil, for the good presentation. Now I'd like to call Dr. Samresh for his final thoughts.
Thank you, sir. Thank you for involving me. And it was really, really nice presentation. I know this is very, very common condition. And although they're rarely referred to the pain physician, the reason being most of the patients they are managed by the gynecologist. They will do the laparoscopy, and all. If everything fails, they will send to us. Okay, so yes, that's why it's more important when maybe the patient comes to you. Maybe they spend around 5 to 10 years sometimes. So it's very important to go thoroughly and like open all other things what we can do best for the patient. And yeah, that's the only thing. It's a nice presentation, to be honest.
Agreed, Dr. Samresh. Thank you very much for being our expert faculty. I think all of
Thank you,
the
thank you, sir.
participants benefited from your expert opinions and expert views on the case. Okay, so again, I'd like to thank all of you for being a part of today's webinar, and soon we will be back with another interesting case. So almost every week we are doing these kind of presentations, usually on Thursdays. We have planned to keep one day wherein we will be presenting such kind of rare cases which we see in our pain clinic, Alpha's multi-specialty pain clinic. Thank you all for joining. Thank you again, Dr. Sunil. Thank you again, Dr. Samresh.
Thank you, sir.